Thank you very much. I thank you for being invited here. This is a very nice environment. So why there is that picture? Now, he cannot know because he's a classic music player. Who recognized the man there? Well, that guy, his name is Van Morrison. Never heard him? He's a... Sorry? Well, okay. And I think that he's a very good blues man. And we are talking today about the Gabba Blues. To go ahead, I go with this, I guess. So this is the title, and I asked him to also write some music, which actually he did, but I didn't get the tape. So you have only to listen to my words. Where it starts, the Gabba Blues? The Gabba Blues starts with my arrival in Montreal in 1979. And why I'm saying this? I'm saying this because I went to work with this man, Peter Gluer, who was at the time working on a model of absence seizures, which I can show you in a few seconds, just as a glimpse of what kind of model is this. A model of absence seizures induced by intramuscular injection of penicillin. Now, this is 79. It's a time when there was no GABA A and GABA B. There was GABA. And actually, this man, his name was Herbert Jasper, was among the team, or in the team, who in 1951 identified something called factor I. The biochemist was Elliott. The guy who did much of the electrophysiology was Hugh McLennan, future supervisor of Itz Van Moody in Vancouver. So this was 1951, 1952, I was just born, and they got GABA in the Montreal Neurological Institute. And then this is the model of feline generalized penicillin epilepsy. A model of absence seizures means generalized seizures with the spike and wave discharges like the absence that you have in a number of children. This is an absence, okay? And the cat does just this during this spike and wave pattern. Now, I just said this was 79. There was no GABA A and GABA B, but there was evidence coming up from Roger Nichol, Per Anderson, David Prince, that penicillin was maybe a weak GABA antagonist. And at that point, there were a number of other people, including close friends of mine like Enrico Cherubini or Ben Ari or Chris Kernievich, saying that during a seizure, you lost the IPSP, which you know is GABA. So Peter Gluer loved to say that this was a too simplistic way. Epilepsy was not equal to loss of inhibition. It was somehow more complex. And this is where I got my interest in getting the role of GABA. By now, GABA A, I would concentrate on GABA A receptor function today, and epileptiform synchronization, as well as other aspects. So, first of all, we'll review very simply and very didactically, like I do with my students of medicine down in Latina, in Italy, the GABA as inhibitory transmitter. Then we'll look at the role of GABA in synchronizing limbic networks, which, as you know, are very important for producing limbic seizures, which are the hallmark of temporal lobe epilepsy. And finally, we'll go and have a fast look at changes in GABA receptor-mediated inhibition in a rat model of temporal lobe epilepsy. Wow. This means that the slide has been exhausted. There is nothing else that I have to say. But I didn't know that it was so loud. Okay. So don't get scared. This is a pyramidal cell. We go inside the neuro, and what we see, this is a recording in presence of glutamatergic receptor antagonist. We see a rather well-known response. The pointer is this? Yes. Characterized by an early and a late phase. This hyperpolarization is very capable of stopping firing, so it's very capable of inducing a period of inhibition. And again, you can appreciate that there is a fast component and a late component here, and that these two phases have two different reversal potential, presumably associated with increase in chloride conductance for the A component and increase in potassium conductance for the B component. Am I clear so far? Nothing really new. Old stuff, right? So, how GABA acts as an inhibitory transmitter? Well, if you look at any classic textbook, they will say that there is an EPSP, and then here it comes the IPSP. If the two come together, they summate algebraically, maybe not, and so the EPSP with action potential will be reduced, and therefore there will be an inhibitory effect. But inhibition is not only due to the clamping effect, the hyperpolarization, but also to the shunting action. So shunting action means that according to the law of Ohm, V equal I multiplied R, which is the resistance of the membrane, GABA A current will increase the conductance, and so will decrease the resistance. And so what you have is a smaller V, so a smaller EPSP. Again, another way to have inhibition. Yes? Okay. So, now, the hyperpolarizing mechanism is nonetheless very important. And not only important, it can be also quite tricky. Why? Because normally you know that chloride inside is less than outside. And so when GABA receptor will make the chloride channel open, you have a flow of chloride inside until they reach the reversal of the equilibrium potential, let's say minus 67 millivolt. However, things will change if the chloride outside increase or if the chloride inside increase. Let's see first what happens when the chloride outside increase. What you are going to have is a shift of the reversal potential to more negative value. And so what you are going to have is that this IPSP now clamps the cell even lower. More difficult for an EPSP to excite. And what happens when the chloride inside goes up relative to the one outside? Well, in this case, you are going to have an excitation. Why? Because the reversal potential will shift towards the positive, maybe even more positive than the threshold for action potential generation. And so what you are going to see here is that GABA can depolarize and excite neuron. Ready? All right. So, the intracellular concentration of chloride is therefore very important, and we know that it is regulated by several cotransporters. One of these, probably the most important, is the so-called KCC2, which is low during the early stages of life, in rodents during the first week, in humans in the last intrauterine period. And we also know that KCC2 expression in adult rat neurons is downregulated following epileptiform activity, as Kai Kaila has shown, or neuronal damage, presumably because BDNF, TrkB signaling downregulate KCC2. So, this is the very first and well-known part of my talk, namely that GABA can usually hyperpolarize, but it can also depolarize, and then that KCC2 is quite an important actor in this kind of story. Now, let's go to limbic seizures and epileptiform synchronization. And this is the typical slice, brain slice, that we use in my lab. The typical slice includes the hippocampus, the entorhinal cortex, the perirhinal cortex, sometimes the amygdala. And we try to make these slice with all these structures interconnected. And you know very well that anatomy and physiology in vivo tell us that from the dentate you go to CA3, CA1, subiculum, and then entorhinal back, or maybe you go towards the perirhinal cortex, the amygdala, the insula, and other structures. Now, GABA is by all means inhibitory, GABA A receptor activation is by all means inhibitory. As much as we work on epileptiform synchronization, it is also obvious that to block GABA A receptor with a substance like picrotoxin or bacuculin is somehow a dead-end experiment, because once you have blocked a GABA A receptor, well, you cannot really know what is the role of GABA. And it is somehow like to see whether a gun can kill, you shoot, yes, it can kill, that's it, finish of the experiment. There is nothing more to be said. Now, the turning point in my, call it, career came in 1984. So 5 years after my arrival in Montreal, I had got my PhD, I went to Per Andersen. Still, I didn't know how to solve the problem, which was if I apply bacuculin, I block GABA A. So then I go home. And I was lucky to visit Dan Johnston's lab in Houston, where a young chap called Paul Rutecki, of my age, was completing his training and was using a different substance called 4-aminopyridine. 4-aminopyridine was well known at the time because it was a potassium channel blocker. So every patch clumper, every guy interested in aplesia, squid, and so on was using it as a potassium channel blocker, using quite high concentration. Paul Rutecki and Dan Johnston were using 4-aminopyridine to work out which was the characteristic of the epileptiform discharge induced by this drug at very low doses. So this was my first encounter. I went back home, I ordered 4-aminopyridine, and I started working on it. And somehow, the good thing of 4-aminopyridine is that it does not block GABA A, does not block GABA B. What it does, it enhances transmitter release, both GABA and glutamate and acetylcholine and this and that. Why? Because at 50 micromolar, that's the concentration we use, 4-aminopyridine blocks some type of potassium channel, the so-called ID, and maybe a bit of IA. And at that point, by blocking potassium channel, make more calcium to enter the presynaptic terminals. If more calcium gets inside, more transmitter is released. And this is what you are going to see during a perfusion of 4-aminopyridine with the slice I just showed you before. You see that you have at least 3 types of activity. First, you have this kind of fast activity, which appears to originate in CA3. Then you have this type of slow activity that sometimes is represented all over the places, and is somehow slow. This fast activity is approximately 1 Hz. This slow activity is 0.01, 0.02 Hz, and even slower. And finally, you have this kind of ictal discharge. As you probably know, interictal and ictal have a limited value, just a phenomenological value in the slice, because ictal means when the patient will have a convulsion, and interictal means when the patient does not have any clinical symptom, but the electroencephalographer will record an interictal between seizure spike. We reproduce the EEG pattern in the slice, as you can see here. Now, this is a typical experiment, and what you see here is that CA3 interictal activity does not propagate to the entorhinal cortex, but just stops at the CA1 level. Now, what happens when we block the GABA receptor with picrotoxin? Well, 2 striking things occur, or maybe 3. First, you see that the ictal discharge disappears. You see that the interictal becomes much more robust, as well as that this interictal propagates now from the CA3 down to the entorhinal cortex. So this suggests that somehow subiculum, which is between the CA1 and the entorhinal cortex, exerts a powerful inhibitory effect, or exerts a gating role that is due to GABA receptor activity. And this is the proof of what I'm saying. If you start from control for aminopyridine, in this case we have the CA3 interictal, you have an intracellular recording from a subicular cell, and you have a field recording from the entorhinal cortex with the slow interictal. Picrotoxin blocks these IPSPs recorded in the subiculum, and this blockade coincides with the ability of the CA3-driven discharge to go to the entorhinal cortex. Okay, so here we have a situation where with 4-aminopyridine we have interictal and ictal activity. We have a situation where the interictal activity have some problem in really propagating easily and nicely unless we block GABA receptor function. Finally, we also have some kind of suggestion that GABA receptor function is needed to have long ictal discharges. If we block GABA, we kill the ictal events. We'll go back to this later on. So now, let's go back to actually our slice. This is an intracellular recording from an entorhinal cortex cell in the deep layers. Actually, this was something done by my old friend and postdoc Valery Lopantsev, who I believe nowadays works with Dragunov, who is in the fellow who was working with Uwe Hahnemann. Dragun.
He is in Heidelberg.
In?
Heidelberg.
Ah, okay. So I think that Valery Lopantsev is there. So what he did is filled an intracellular recording from an entorhinal cortex rat in a slice, and you see that foraminopyridine will induce this nice, long-lasting ictal discharge with the intracellular counterpart here. Also some slow interictal, another nice discharge, and a spreading depression. And this, I think, is a potassium recording during this type of activity, showing the transient increase associated with the slow interictal, as well as this type of long-lasting increase in potassium during the initial ictal spreading depression event. Now, what happens when there is an interictal discharge? We have seen it before. What happens when there is an ictal event, and especially at the beginning of the ictal event? Okay, this is an expanded trace of the intracellular recording performed at resting level from the entorhinal cortex cell, like the one that we have seen before. So we expand the trace, and what we see here is that the beginning of the ictal discharge is characterized by this slow depolarizing event associated with not so many action potential. Then later on, as the ictal activity becomes conclamate, lots of action potential activity will occur. Let's do a classic procedure for everybody who works in current clamp, especially with the old-fashioned sharp electrode approach, which is depolarize and hyperpolarize the membrane. And actually, let's depolarize. And what you see here is that, in fact, the ictal discharge is preceded by a hyperpolarization, presumably due to the activation of GABA receptor, suggesting that GABA may be instrumental in initiating the ictal discharge. If you have a question, please interrupt me. Now, this phenomenon is not only seen in the lab in the slice dish. It's also seen sometimes in human patients with temporal lobe epilepsy. This is courtesy of François Dibot, where left and right, several hippocampal and parahippocampal structures recorded. You see that this slow interictal type of event will make the ictal synchronization occur on the right structure of the limbic system. Let's try to establish that what I call slow interictal is indeed GABA, or GABA A receptor mediated. Here you see, first of all, an experiment where foraminopyridine was applied to a slice containing the hippocampus proper, perirhinal cortex, and insular cortex. You see the typical interictal generated by the CA3 network, and then you see also the slow GABA that sometimes occurs synchronously or asynchronously. Is not really relevant for the purpose of this experiment. We apply glutamatergic ionic receptor, ionotropic receptor antagonist, CPP and CNQX, and as you can see, the fast interictal generated in CA3 is blocked, but the slow interictal continues to occur. Let's now go to another type of experiment. We start with the CPP and CNQX already in the bath. So glutamatergic ionotropic is blocked. The slow interictal is occurring, we apply picrotoxin and we abolish this synchronous event. So pharmacological proof that what we are talking about here and here is GABA A receptor mediated. Now, intracellular proof. In addition to the reversal potential that with QX314 field sharp electrode is around minus 35 millivolt, the proof is that if we record with a KCl field electrode, this is the beginning of the recording, and this is after 10 minutes. KCl electrode is filled with chloride, which over time will go inside the cell, so it will load the cell. So at the beginning of the experiment, there will be little drive for chloride out. Actually, will be a lot or some chloride getting in. But after 10 minutes, as the cell is loaded with chloride, chloride will start going out if GABA is doing something on GABA A receptor. And this is the case. The last point of this slide is that, in fact, every time you have one of these field potential event recorded with the glutamatergic receptor antagonist, you have a transient increase in potassium. We have done quite a number of experiments, and actually the potassium experiments were in large part done with Rüdiger Köhlig, who I believe was somehow also in this institution at one stage of his career. But I don't want to spend too much time on it. These are experiments that go back to mid-90s. I would much more like to show you that what I just said in the slides also occurs in a preparation that is called the guinea pig isolated brain preparation. Developed by Rodolfo Linas in the early 80s, spread around the world. Basically, he was killed or he died everywhere but in one place. This place is Milano. The laboratory is Marco De Curtis' lab, where I am proud to go to pay a visit once a month, in addition to being in Padua for sentimental reason, in Rome for didactic reason, and at McGill University, because that's where I love to be. Now, with Marco, we have been working with 4-aminopyridine in this preparation, and obviously in this preparation as well. 4-aminopyridine will induce ictal events that are very similar to those we have seen in the slides. There are questions about the detail of this preparation because you probably know how we slice. Take the brain, tzack, 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 tzack. Take the slice, like if it's a salami, put it in the dish and do the experiment. Now, this is a quite complicated experiment because you have to take the brain out of the skull, keep it nicely intact, incannulate the carotid, push the artificial cerebrospinal fluid, and then you can record. Obviously, the disadvantage is that the pharmacology is a bit like when you are in vivo. You apply drugs, you don't know exactly the concentration you are applying when they reach the brain. But you have there your brain, and then you stick electrode knowing where you are hitting. All right. So, in this preparation as well, 4-aminopyridine induce epileptiform discharges. This is wrong, I'm sorry for this. This, I think, is from here to here, 40 seconds. So, nice epileptiform activity, and when we block the glutamatergic transmission, also in this preparation, we have these kind of slow, presumably GABAergic events, which are in fact decreased, not completely abolished, by the GABA A receptor bacuculin. So even in a whole brain, we can have GABA receptor-mediated synchronization that makes neurons to go together. Indeed, and we don't know how to explain this. This mechanism is able to make the slow GABA receptor-mediated event to go from one hemisphere to a contralateral hemisphere, maybe through a potassium increase that travels through the corpus callosum, we don't know. But this is what we can see in this preparation. And finally, you see that basically the intracellular counterpart of this phenomenon is very similar to the one we see in the slides. A depolarization with action potential at resting membrane, as well as that when we depolarize the cell, we can reveal an hyperpolarization. Now, I hinted before that GABA, A receptor-mediated synchronization, can kick the neural network and make a nictal discharge occur. Again, you see here, for aminopyridine in the bat, control the slow ictal, the fast CA3 interictal, prup, 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 psh, prup, 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 and so on. And then you see here that you have presumably a slow interictal that goes into a long period of ictal synchronization. We reasoned that if it's true that GABA is so important in making the network go into a nictal event, then abolishing GABA function should abolish ictal discharges or ictogenesis. Is this correct as a possible hypothesis? If something makes something, you kill that something, and the second something doesn't occur. So GABA is responsible for ictogenesis. Let's block GABA, and if we are right, ictogenesis will not be there. And this is what happens with DAGO, which is a mu-opioid receptor agonist, and you know that by applying a DAGO and activating mu-opioid receptor agonist, we hyperpolarize interneuron and we release GABA, and we reduce GABA release. As you see, accordingly, this is just the washout, but as you see, this slow interictal, which is GABA mediated during DAGO, disappear, as well as the ictal discharge. Again, going back to my friend Rudiger Köhlig and another friend of mine called John Jefferies, they showed the same in a different preparation. This is zero magnesium, this is hippocampal slice, and what John and Rudiger did, it was to show that under controlled condition, you can have prolonged ictal discharges that are blocked by bicuculin, which is another GABA A receptor antagonist. So, second part of the talk, the third is very short. So then we have hamburger, hot dogs, whatever. It's all there, believe me. I know, I didn't see it. There is some? So we did the second part, and the take-home message of the second part is that GABA is true that can play an inhibitory role, but it is also true that under some circumstances, it can be able to facilitate ictal synchronization in this type of preparation. So, which is the third one? The third part, it was temporal lobe epilepsy. Well, temporal lobe epilepsy studied by using the pilocarpine model. Here is a general type of schema where you see here the insult, status epilepticus, latent period, and then recurrent epileptic seizures. Now, you very well know that this is what happens with the cainic acid injection, with pilocarpine injection, systemic, locally, with the electrical stimulation continuously, or with the Kinglin procedure, a bit different situation. But basically, the point is that you have to get this insult. And we also know that the insult in the human condition is the febrile seizure, is the encephalitis, is the kid who fell from the chair. Now, insult, and after a few years, we have a temporal lobe epilepsy patient who will walk the main door of this clinic. This is what characterizes a pilocarpine-treated rat brain. You see there is cell loss, and this is usually characterized by cell loss in the entorhinal, in the medial entorhinal, in CA1, CA3, and hilar cell. You see here the cells of the hilus of the netagius. And this is a typical seizure recorded with the surface and depth electrode from one of these animals. What we have seen in these animals by looking at excitability in a slice preparation? Well, we have seen that generally there is an increase in excitability. As you can appreciate, for instance, look at subiculum, non-epileptic control, and pilocarpine. There is a shift towards the left of the input-output curve. 200 microampere in the neck does not induce any response. 200 nanoampere in the pilocarpine induce a depolarizing response with two action potential. There is somehow a decrease in the number of spontaneous IPSPs that you see in the lateral amygdala of a non-epileptic, and you don't see in a pilocarpine treated, where in fact you see this kind of spontaneously occurring burst. You see a shift towards the depolarizing direction of the IPSP, of the reversal potential of the IPSP, meaning that the IPSP is less able to clamp the membrane down. And as a summary of 4 different structures that we have analyzed in pilocarpine, comparing it with the non-epileptic control, you see that basically there is spontaneous discharges in entorhinal, perirhinal, and lateral amygdala, which are not present in the non-epileptic control. We have, most of the cases, a shift in the depolarizing direction of the IPSP. You have a KCC downregulation assessed with biochemical, histochemical approaches. And you have also an interneuron decrease in number, as shown also by Buckmaster and other authors around the world. So basically, in this chronic model, there is, during the period of recurrent seizures, there is somehow an increase in excitability and a decrease of several parameters indicating the function of GABA inhibition. In the last year, we have been working on something that is somehow new for my lab, and basically we have extended the vision from phasic also to tonic inhibition. And this is just a sum up of the story of phasic and tonic. You are familiar with it, I believe. GABA, when is released from a synaptic terminal, will activate synaptic receptors and will cause a phasic hyperpolarization, the IPSP. But when there is a spillover or ambient GABA itself, will activate the extrasynaptic receptor, then there will be a tonic inhibition that actually is more evident when you apply the neurosteroids such as alloprogesterone. Now, we have been looking at pilocarpine-treated rats by analyzing in particularly the phasic and the tonic inhibition. I would say that so far we have looked during the latent period. We still have to look at the chronic period, but preliminary data indicate that during the latent period, GABA phasic inhibition is characterized by a slowing of the kinetics of these IPSCs. As I said, this is solid preliminary evidence. In addition, and this has been actually published in over 15 neurons recorded in pilocarpine as compared to the equivalent number in non-epileptic control, we have shown that tonic inhibition is increased during the latent period, suggesting that somehow after the insult you have an attempt through GABA to rescue, to avoid that seizure will occur. So, again, as I said, in chronic epilepsy, evidence suggests that GABA inhibition is decreased during the chronic period. This is pretty solid, shown in our experiment and in a number of experiments from all over the world. During the during the latent phase, it appears that for sure tonic inhibition is upregulated, and maybe phasic inhibition is somehow changed in such a way that the IPSCs and therefore IPSPs are more prolonged. I think that this is the last point. Now, there is also other possible effects for GABA. For instance, since I come from Italy, I cannot avoid to think that some of the effect that happened to the hair of Berlusconi may be due to GABA receptor activation. But whatever is your taste of politics, I have to thank these people here. She is the one who did the patch. She is the one who started, or better, restarted the chronic experiments, and this is her successor. And now this is the Montreal Neurological Institute, ready for the flags, which includes also your flag. Thank you.